Beyond the catheter, alternative sources of Corynebacterium jeikeium bacteremia. While Corynebacterium jeikeium bacteremia in the oncologic setting is frequently attributed to central venous access devices or ports, a reflexive diagnosis of catheter-related bloodstream infection can lead to overlooked primary sources. As a lipophilic, multi-drug-resistant commensal of the skin, C. jeikeium possesses a unique ecological niche that clinicians must account for, particularly in the context of chemotherapy-induced immunosuppression. The most prevalent non-catheter source is the skin and soft tissue. C. jeikeium exhibits a high density of colonization in the inguinal and axillary regions. In patients undergoing cytotoxic therapy, the integrity of the mucocutaneous barrier is often compromised. Whether through venipuncture sites, surgical wounds, or subtle chemotherapy-related skin breakdown, these breaches serve as the primary portals of entry. Landmark studies have demonstrated that in nearly two-thirds of oncology patients with C. jeikeium sepsis, a definitive mucocutaneous breach was the origin of infection. A second, often under-recognized mechanism is chemotherapy-induced mucositis. High-dose regimens can cause extensive gastrointestinal mucosal barrier injury, facilitating the translocation of colonizing organisms directly into the systemic circulation. This shift toward gram-positive bacteremia is a well-documented phenomenon in the modern oncology era, where the gut serves as a reservoir for translocation, even in the absence of a primary focus. Beyond these common sources, clinicians should remain vigilant for specific clinical manifestations. C. jeikeium can present as a respiratory pathogen causing pneumonia in the critically ill, or as a dermatologic phenomenon characterized by erythematous or hemorrhagic papular eruptions. These skin lesions are not merely symptoms. They can represent a significant bacterial burden and a source of persistent bacteremia. Furthermore, while less common, the potential for infective endocarditis, particularly in patients with prosthetic valves, must be considered as a serious sequela of high-grade bacteremia. It is vital to note that while granulocytopenia is a major risk factor, it is not a prerequisite for invasion. In non-neutropenic patients, the skin remains a highly probable source, especially when selective antibiotic pressure from prior broad-spectrum therapy has favored the overgrowth of multi-drug-resistant C. jeikeium strains. For the clinical team, there are 4 key take-home points. First, perform a meticulous physical exam of the axillary and inguinal regions. Skin colonization increases significantly with hospital duration and prior antibiotic exposure. Second, do not assume a negative line culture rules out C. jeikeium sepsis. Evaluate for chemotherapy-induced mucositis or skin breakdown as potential alternative drivers of translocation. Third, recognize the pathognomonic potential of papular skin eruptions. These can be the smoking gun for a non-catheter primary source. And finally, consider the role of antibiotic selection. C. jeikeium is notoriously resistant to most non-vancomycin regimens, and its emergence often follows the use of broad-spectrum beta-lactams. By broadening our diagnostic lens beyond the port, we ensure a more comprehensive approach to the management of this opportunistic pathogen.